Welcome to this, what's now becoming an annual collaboration between the Stanford Palliative Care team and the MERI Center for Education and Palliative Care at UCSF, with some other friends and palliative care family from around the Bay Area. My name is Redwing Kesar. I'm a palliative care nurse and educator, and I will be kind of giving the outline and hosting of today. Let's just go ahead and do some first we're going to do some very brief introductions of who the players are on the screen. They will do a more in-depth introduction as we go into today's program. But let's just let you know who everyone is. So Ramy.
Hi, I'm Ramy Salah. I'm a palliative care physician with the Alto Medical Foundation out of San Mateo, California.
Great. And Naomi?
Hello, everyone. My name is Naomi Sachs, and I am a palliative care chaplain with the University of California, San Francisco, here in San Francisco.
Great. And Anne?
Hi, everyone. My name is Anne Kalnasaga. I support the Palliative Care Center of Excellence here at Stanford.
Great. Meg?
Hi, I'm Meg Mendiola, nurse practitioner in palliative care at Palo Alto Medical Foundation in the Sunnyvale, California clinic.
Great. And Jacelyn?
Hello, my name is Jacelyn Hill. I'm the palliative medicine medical social worker at Stanford Healthcare.
Great. Gail?
Hi, I'm Gail. I'm the program manager at the UCSF Division of Palliative Medicine, as well as the UCSF MERI Center.
And Grant?
Hey, I'm Grant Smith. I'm one of the palliative care doctors at Stanford, just working behind the scenes on the webinar today.
But thank you for all that behind the scenes and really making this happen, Grant. So, well, again, just welcome to each and every one of you. Gail has put up some basics on the screen about Zoom webinars. We're kind of assuming at this point in time that most people know how to do this. We will do Q&A at the very end. The way we've been running these webinars is that we are going to offer up a case scenario of a real case, and then we're going to have each person on the palliative care team sort of give you their perspective on this case, so that we're really modeling for you what a team-based interdisciplinary discussion might look like. And then at the very end, we will certainly have time for questions and answers. We want to start with the umbrella of a definition of palliative care, which, believe me, there are many definitions. It takes a lot of people a lot of time to come to agreement. But the one we're using today, just so we're all on the same page, is that palliative care is both a philosophy of care and a type of medical care for people who are living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of a serious illness. And the goal is to improve the quality of life, not just for the patient, but for the family, for whoever is supporting that person. And it takes into account not just physical suffering, but mental, emotional, psychological, and spiritual suffering as well. That, as we all know, often accompanies, most of the time, accompanies a serious illness. Palliative care is ideally provided by a specially trained team of physicians, nurses, social workers, chaplains, sometimes volunteers, sometimes pharmacists, who really work together with a person's other clinicians in order to provide whatever support is needed. Palliative care is appropriate at any age, at any stage in a serious illness. It can be provided along with curative treatment, and it is not the same as hospice care. Palliative care is really its own thing. And as you will see today, this idea of an interdisciplinary team of people offering their expertise from their perspectives is what part of makes it so potent. Okay, so our team is going to hear the brief details about this case, and then each panelist will give you their perspective. So here's our case for today. Our outpatient palliative care team is preparing to see Mr. Patrick Jones for the very first time in clinic. Mr. Jones is a 72-year-old man diagnosed with Parkinson's disease 10 years ago. His symptoms include slowed movements, stiff muscles, shaky hands, and difficulty with balance. Despite adjustments to his medications, he recently began feeling too unsteady on his feet to go out for date night with his wife, and he has now started using a walker. His Parkinson's disease specialist has referred Mr. Jones to palliative care for help with planning for the future and extra support for the patient and his wife, who are both pretty distressed by this recent decline. So I'm going to turn to our social worker first, and with the question, what would you be thinking at this point of knowing this patient, Mr. Jones? What would you want to know more about? And a little bit about your role as a social worker.
Hello, again, my name is Jacelyn Hill, and I'm the social worker on the team. And one of the things that I would first think about as a role of a social worker is a psychosocial assessment as I'm meeting Mr. Jones and his wife. And in that assessment, I would be assessing his social supports, family members, people who are available for caregiver support, and just seeing what type of more practical supports they may need in the home environment, and also looking at psychosocial supports. And another area that's important that the palliative social worker likes to look at is how the patient and the spouse are coping. So I would make sure that I would assess how they're coping emotionally and mentally, especially with the recent changes and decline with him, because it can look different from how the patient is coping versus his wife. So making sure that we assess that during that initial assessment.
Redwin, you're muted.
Thanks, Gail. And thank you, Jacelyn. So I'm going to give you a little bit more information from hopefully to answer some of the questions that you just brought up. And then we're going to hold this information until everyone has a chance to speak and have more of a discussion. So just what we're going to let you know here is that Mr. Jones is a retired regional bank manager. He and Jeannie have been married for 45 years. They have an adult daughter who lives in New York. And although they talk to their daughter regularly, she's really busy with her own family and she's rarely able to visit. Outside of each other, Patrick and Jeannie don't have many friends or other social supports, and they live on a fixed income. They're wondering about getting a disability placard given Patrick's difficulty walking. And Patrick expresses worry about being a burden on Jeannie. And he wonders, what am I going to do if things get worse? So this is something to hold as we consider this case from the point of view of chaplaincy.
Hi, again, I'm Naomi Sachs. I'm the palliative care chaplain on the team. And some of the things I might be looking for Mr. Jones and his wife and family is this whole idea of spiritual, existential, religious, and cultural needs. So as his body declines with Parkinson's, I'd be wondering, is there any existential distress, identity issues about his personhood, about who he is in the world? spiritual distress, connection to other, or connection to something greater than himself? Might there be also room for how he's making meaning? I would want to know, how is he making sense of this? He's been living with this for 10 years, and now his condition has changed, his body has changed, his relationship with his wife has changed. I'd also want to know, what might they turn to in challenging times to help them cope, such as prayer, nature, each other, sometimes meditation, or other things. I'd also want to know, what is their belief system about what this means, what this serious illness means to them and to their sense of self in the world. And then also, what brings him joy still? What are there moments of peace? Are there moments of respite? Are there also moments of healing that we can also help support? And last, are there any practices or rituals or community? For some people, it can be a walk every day in nature. For some people, it can be prayer or going to a spiritual, religious, or supportive community. So those are some of the things I'd be wondering.
Thank you, Naomi. Thank you so much. So what we do know is that Mr. Jones is not religious, but he describes himself as a spiritual person. And Jeannie reports that she is a Presbyterian, but that she doesn't really attend church, but she does pray daily. And Jeannie wonders, why did this happen to Patrick? Did they do something wrong that made Patrick get this disease? So holding that information, I'm going to go on to the medical perspective from Ramy.
Hi, again, Ramy Salah with the Palo Alto Medical Foundation. You know, one of the things that I would want to touch on with Mr. Jones is a symptoms assessment. I know Jacelyn and Naomi are already talking about psychological, emotional, spiritual symptoms that he and his wife might be having right now. I also want to touch on the physical, especially with Parkinson's and it being a neurodegenerative disease. Some of the things that we think about are unsteadiness. Has he had any falls at home? Any trouble swallowing? Does he feel confused? Has his wife picked up on any confusion, restlessness, or agitation so far since he's been diagnosed and now 10 years later? I'd also want to see if he's been following up with any of the support that we can offer at home, like home health. So I know we talked about the key members of our palliative care team, but there are some extended members too with home health, say physical therapists, occupational therapists, home visiting nurses, speech and swallow therapists as well, who can really help patients with Parkinson's disease. So I'd want to make sure that they've been plugged in, even if he's not having, say, falls or trouble swallowing. The best time for them to get involved is before those symptoms really get out of hand, if for anything, so that Mr. Jones and his wife know what kind of supports are out there and available to them once things, or if things get more difficult. And then lastly, I know for many doctor's visits, it feels rushed, right? It feels as soon as you get checked in and get your vitals checked, you're already being asked to leave, or the doctor's kind of inching towards the door because of how impacted clinics are. And thankfully, for most palliative care clinicians and doctors, we're able to afford a little bit more time. And so I want to make sure just to collaborate with, say, his neurologist to clarify any medications questions, to listen and hear what Mr. Jones took from his last appointment with his neurologist, and see if that kind of links up, if they took home an understanding that kind of fits with where he is in his course and treatment plan. So those are the things that I'd want to check in, especially during my first assessment with Mr. Jones.
Great, thank you so much for all that. What we do know about Mr. Jones is that he is working with PT regularly. He feels like it's really helped him to remain as active as possible and delayed the need to use a walker. He does have regular follow-ups with his neurologist. And at this point, luckily, he has no signs of dementia. He doesn't have trouble sleeping or swallowing right now. So that's some of the good news. And let's go on to the role of a nurse practitioner on the team. So Meg.
Yeah, hi, thank you. Along with Dr. Salah, part of the role of the nurse practitioner is also to kind of check in on symptoms and see how we can support kind of quality of life by managing those symptoms. Other things that we like to do that I would probably do, especially in a first visit, would be to check in and find out how much Mr. and Mrs. Jones know about the typical course of Parkinson's. We often provide a lot of education around kind of disease progression and prognoses so that we can help the patients and families be really better prepared to navigate their future and anticipate what changes might be coming up down the road. I also like to check in on advanced care planning, check in and find out if they've completed an advance directive. If not, kind of go over what that means and why it's important to designate a healthcare agent so that if there comes a time when Patrick or Mr. Jones can't make his own decisions, that we understand who best could help make those decisions for him. And along those lines, these conversations often kind of, we address goals of care as well. And really, we just want to find out from our patients and families what is important to them. And so as time goes on, we help try to make sure that care they receive from all of their medical teams is really reflecting their values and their wishes. And these are often ongoing conversations that kind of change throughout the course of the disease as patients' conditions change as well.
Thanks, Meg. Yeah, I think that's an important point, that these are ongoing conversations and this conversation changes over time, but it's so important to keep revisiting it. So just a reminder to the audience, if questions come up as you hear all this, feel free to just put them in the chat and we will get to them at the end. So, here we are ready for an actual team-based discussion. We've had a little more information beyond the first snippet of this case of Mr. Jones. And so I'm just going to ask you to pretend you're in a real room with each other. How would you talk about next steps? How might you collaborate with each other, with members of the extended team, as Ramy suggested? Where do you think this would go in your discussion of this patient? Why don't we start with Jacelyn, and then you can just pass it around, just trying to have a normal conversation about this case.
Yes, I would talk to the team. One of the things that when you just talked to us about was that the practical resources and that they needed a disability placard. So I would make sure that I would update the team and Mr. Jones and his wife that is something that I could assist with coordinating to have the disability placard completed, the paperwork, working with Dr. Salah and the physician signature, making sure that he's able to sign off on that. And then also exploring, as Meg was talking about, those goals of care discussion. I would talk to our team along with Mr. Jones and the wife and making sure that we're documenting that through the serious illness conversation. It's so we know their wishes and providing them with that healthcare advance directive document if they don't have that or have never seen that. So letting them know that we're here again to be a support and completing that with them, alongside them, if they need that support. Another thing that I would touch on is maybe the resources linkage, telling the family about caregiver support groups, things of that sort that could be available for her. And then if they did have some ongoing depression, maybe, or anxiety about coping with this illness, making sure that I'm able to provide them with those resources for mental health support, and knowing that I'm available for that supportive counseling as they continue and meet with our entire team. And just making sure that the family has the tools right now, and as they are adjusting to working with the interdisciplinary team. So continuing to educate them of what's available from a psychosocial support. I'll pass it on to, let's see, Naomi.
Thank you. As Jacelyn said, I would work with my team. I would want to know what information they found out, because as we know, everyone's experience, it's not separate siloed experiences. If somebody is having pain, it can be physical pain, it could be spiritual pain, it could be all different, it could be social pain. And so I really want to hear what my colleagues found out, and we would all talk together and sort of share our ideas. And also share what we learned and what we were told. I think then I would sort of look into a couple of things that Red Wing mentioned in addition, the additional information. One is Mr. Jones is spiritual. I'd want to know, are there practices that support him? What does spiritual mean to him? How do we bolster that in this experience? And what does he need around that? Jean, his wife, turns to prayer. Is this something that she's able to access easily? Can we help her, support her? Does she need a community or other people in her community to help support that? Are there prayer circles? Are there other things that she's turning to family? She also had this question, why is this happening? That's such a human question. And that's one that I probably would explore with her and possibly Mr. Jones as well. This idea of I've lived a good life, or I've been a good person, or this is just not how I thought life would go. And why is this happening? It could be a question for God. It could just be a question for life, and really saying, why is this happening to me? And that's a really important question to sort of unpack and help people find their own meaning and identity around that. The other is a whole idea of date night that was mentioned. I would just also want to know, how are they connecting, and are they finding like beautiful moments or moments for love or moments for connection that they can still find nutrition from their heart. And the last is so much part of advanced care planning is values. So I would want to make sure I understand how these religious and spiritual and existential meaning making, how this impacts their values, and how these values impact their healthcare decision making, because we always want to make sure we lead with those. What's important to them? What's important, and how do we support that?
I can jump in. After my first assessment with Mr. Jones, I truly think that, say, a doctor, Meg, I'm going to speak for you here, a nurse practitioner is probably not on the front line. It's more Jacelyn and Naomi, because of what I heard from the information they've been able to gather, right? We heard Mr. Jones say he didn't want to be a burden on his wife. And maybe he's already picking up on that, especially her questions like, why is this happening to me? It sounds like she's already having some psychological and emotional burden because of what her husband's going through with his Parkinson's. So there's social or psychological, there's emotional, there's spiritual. And so, we would kind of talk about that as a team. Hey, physically, he is not even needing to use a walker right now. So he's not having any trouble swallowing. He's no confusion or dementia symptoms. So we can kind of take a back seat, maybe follow every few months or so to pay a visit with Mr. Jones and his wife. But I'd really rely on Naomi and Jacelyn, not just to do the amazing things that social workers and chaplains do, but also because we work as a team, Jacelyn and Naomi would kind of be my ears and eyes when they see Mr. Jones. So Naomi and Jacelyn, part of their assessment would be assessing for any falls, any trouble swallowing, any new symptoms, and then can relay it back to me to see, okay, maybe we do need to have a visit now to discuss this new symptom that's coming up. And that's kind of how we would work as a team, and kind of use each other, right, in our own assessments and screens to see where Mr. Jones is. Meg, do you have anything to add?
No, I totally agree. I think the psychosocial and spiritual aspects seem really like the main areas where support is needed at this point. I will say sometimes, I will check in with the neurologist or, other specialist appropriate to the diagnosis, just to kind of make sure that they're aware that we're following along, kind of talk about what their sense is as far as the prognosis for the patient and how they think we might be able to best provide support if there are areas that we aren't seeing from our end, if they have a specific concern in a symptom management area or anything else, any other way they feel the patient could use our support.
Great, thank you all. And just again, a reminder to the audience that we will do Q&A in a little while. But we're going to give you a little deeper dive into this patient, because the truth is, after Patrick and Jeannie Jones had their initial visit to palliative care, surprise, they felt better. And they felt that their needs had been met. They continued to follow up with their Parkinson's disease specialist, and they were really doing pretty well for a while. They felt this incredible support from this interdisciplinary team. However, 5 years later, Patrick and Jeannie return. Now, Patrick has advanced Parkinson's disease. He's really only able to get around in a wheelchair, which was very hard for him. And he's also developed some Parkinson's-related dementia. At times, Patrick can get really angry. He lashes out at Jeannie. They may have some loud outbursts at night. It's gotten very challenging emotionally. Jeannie finds these episodes very upsetting. And she's starting to wonder, is it time to consider something like hospice? Is it time for placement? What's next here? And it's just a bit more scary of a scenario. So given this information, that now you're seeing this patient, let me again turn to our team and ask, what's next now?
I would say, first of all, making sure that I'm able to provide that emotional support and just validating how the wife is feeling about these changes, and exploring just different options of support. I think I would suggest a family meeting with our team so that we can provide that psychoeducation around what a transition to hospice would look like and what those supports would look like for herself and for Mr. Jones. Another thing that I would maybe circle back to is the daughter, seeing where the daughter is at in a place of supporting the spouse right now. Now that we are seeing them 5 years later, did the daughter move to their location as far as state-wise to be closer to provide support, and just seeing if there's other family that has been in the picture during this last 5 years. So I think a reassessment would be important, but definitely making sure that our palliative team could provide a family meeting by Zoom or in person to really talk about if hospice is appropriate, and relying on our nurse practitioner and doctor to be able to give that medical rationale why hospice may be the next step, since that would be a new topic of support for Mr. Jones and the wife.
Thanks, Jacelyn. So now we're at a different place in the illness, and that means that this family and this whole community and everyone who loves them is a different place too. So I'd be starting to think that first is the caregiver burden for Jeannie. A lot of the focus of the active interventions are focused now on Jeannie because she's the primary caregiver and she's the one that we'll be interacting a lot with a lot of words and language and conversation. So I'd really want to see how she is coping. I'd also want to look at Patrick and see, is there a dementia-related spiritual and existential support that we can give them? We do a lot of support for people with dementia, whether it's companioning them, using music, using visual arts, and other ways of helping them connect, even when cognitively they're not the same person, but the disease has advanced. The other thing I'd be wanting to know, and Jacelyn mentioned this, is prognosis from my physician and nurse practitioner colleagues. Just what are we looking at? Are we advanced? Do we think that it could happen at any time? Because what I'd want to start helping Jeannie and Patrick and their daughter and the family is to start thinking about end of life, and what have they ever thought about death and dying, and what's most important. Is there a legacy that this family wants to help create for Patrick? Is there life review that they have to be doing to review the stories and the joys and the importance of this person in their life? Are there times to think about rituals at end of life or ways that they need extra support? And that's a big part of probably I would be looking at now, in addition to supporting them along the way with this decline.
5 years is a good amount of time. So over these 5 years, whether it was my visits or doing joint visits with the colleagues on the team, we've gotten to know Patrick, right? And the question that Meg astutely brought up at the beginning, what quality of life means to him. And he mentioned briefly what, one of the things that he couldn't imagine living with is that this idea of being a burden to Jeannie. And even if he is now confused, maybe unable to have a coherent stream of thoughts to put things into words, we've been having these discussions over 5 years. One of my favorite parts of introducing palliative care to patients and loved ones is that, we really take the time to get to know you as a person, not just a patient. And immediately I see people nodding their heads when I say that. And it's true, right? We really want to hear about those values that Meg brought up, those priorities, and that way the care you get matches the care you'd want. Now he's having new symptoms. And so this confusion, this agitation, lashing out at his wife, we know that this is part of the progression of Parkinson's disease and dementia related to it. And so I would have an honest conversation about the potential harms and benefits of using medications to help with these outbursts or this confusion. We tend to try and avoid those medications. However, when either patients are going through a quality of life that's unacceptable to them, or if loved ones or caregivers are in danger, sometimes we use that to kind of weigh what to do with the medications for his behavioral symptoms. And so that's part of it. I'll go back to the symptoms I asked about at the beginning. Is he moving around? Is he eating? How much is he eating? And those questions kind of help with prognosis and planning, life planning, looking ahead. I'll turn it over to Meg now to add anything that I've missed.
Yeah, no, I totally agree. I think addressing the symptoms or the behaviors that really might be affecting quality of life for both Mr. Jones and his family is so important. Again, I mentioned, maybe checking in with the neurologist, see if they think that maybe some of the Parkinson's medications might be contributing to the confusion or the behavior, which in some cases they can have that effect, and just kind of making sure to work with the other teams to make sure the medications are at a good level before making changes. But then oftentimes, having that discussion with family about what we might be able to provide to try to help manage the symptoms.
And
Right. Go ahead, Ramy.
One more thing that popped into my head, Red Wing, that you had mentioned about Jeannie bringing up this idea of hospice care, right? And I think at this point is a good time to introduce the philosophy of hospice care, what would be provided with hospice care as opposed to the palliative care, follow-up visits that Mr. Jones has been receiving over the last 5 years. And so if after talking to the neurologist, after our own assessment, Mr. Jones looks like he has a life expectancy of 6 months or less, and the goals are comfort, right? Most people who want to make a transition to hospice really want to focus on comfort when it comes to end of life care and planning, and being usually at home, although hospice can be provided in a number of settings. And if those conversations, how they go, usually I'd offer a hospice informational visit, so Jeannie can ask questions, family, daughter, maybe she's in town, can ask questions, maybe they can clear up misconceptions about hospice care. And of course, as a palliative care clinician, I don't know, I have a hard time letting go. So I always tell families, now you can always, hospice or not, you reach out to me if there's anything I can help with. So just wanted to make sure to add on to that hospice. And if there are questions about the differences between palliative care and hospice, I'm sure we can devote some time to that in the Q&A.
Absolutely. Thanks so much. Thank you all so much. I'm hoping that our audience has gotten a really good picture of how a palliative care team works. These have been great discussions. And as Ramy said, if there are more questions about hospice and palliative care, we can certainly answer those. But I'm going to turn it over to Gail to moderate the questions that have already come up on the screen, and we'll go from there. But thank you so much, everyone, for such a rich discussion about this patient.
Thank you all. We do have some questions, and I am curating these so they're out of order than what you have on the screen. And I'm going to start with a question for Meg. Meg, how do you know when it's time for palliative care? If you're a patient or a family, how do you know when it's time to get a referral?
That's a good question. I think really any time that there is a serious illness that is affecting a patient and their family, affecting quality of life, and causing stress, whether that's, with symptoms, physical symptoms that are taking away from quality of life, or this burden maybe that the patient or the family is feeling as they try to navigate, the difficult emotions and psychosocial, spiritual, financial stresses that can come along with serious illness. I think if you're listening to this and you feel like maybe you're in a position where palliative care might help you, I would encourage you to talk with your other providers, whether it's your primary care team or a specialist, and see if that's something that might be available to you and if they would be willing to put in a referral if you're in a system that has palliative care.
Right. Thank you. Kind of just getting a little more granular and addressing this particular question. If a patient had a movement disorder and was falling a few times and having difficulty swallowing, would you feel that would be an appropriate referral to palliative care?
It does sound like it. It's a little bit difficult without knowing more specifics about the person and the diagnosis and the prognosis. But yeah, I think if oftentimes these signs, as more symptoms are coming up or big changes are happening, maybe if there are more falls, going in and out of the hospital or in and out of the emergency department, those are often kind of signs that more support is needed in managing the illness. And I think that is a good trigger often when we look at a person who's having repeated visits to the hospital or the emergency department, that, maybe we should check in and talk about how we can support and make sure that they're getting the care that they really want.
Thank you.
I just want to add in here that one of the issues that is a reality that comes up in all of our healthcare systems is that not all clinicians understand what palliative care is. Not all clinicians understand the benefit of referring to our palliative care teams. And so sometimes as a patient or as a support person for that patient, you may have to push a little to say, I understand that palliative care could be helpful to us right now. There's an occasional doctor who feels a little threatened by, oh, you think I can't do it all? And, we work in a system that is not perfect. So just want to encourage people to advocate when someone does have a serious illness, even if it sometimes means pushing a little harder than feels comfortable.
Thank you. Next question. Oh, sorry, go ahead, Ramy.
I was just going to say, chances are, if you're asking yourself if it's the right time for palliative care, then it probably is. And, if after the first visit, you meet the wonderful people on the palliative care team and you feel like, okay, I got a sense of what palliative care can provide, but, no follow-up needed at this time. Hey, we followed Mr. Jones for 5 years. So who knows, in 3 months time, 6 months time, 1 year, whatever it is, to phone back to the palliative care team. So I always say, hey, earlier the better. And if it's on your mind and you're really suffering in one way or another, or your loved one is, then it's a good idea to ask for that.
Great point. Thank you. Next question is for Jacelyn. How do we access a palliative care team? How do you get a referral? Who could a referral come from?
I'm going to say, similar to kind of what Meg was just speaking about, a palliative referral can come from your primary care doctor or a specialty doctor. And what in our system within Stanford, they would place the referral, and then we have a scheduling team that would then go ahead and we would meet with them. So that referral can come from one of your other doctors that you are meeting with. And as Dr. Salah was saying, if you feel that you're having some changes in symptoms and you're questioning if palliative is appropriate right now, and I think it doesn't hurt to advocate for yourself as the patient, or if your loved ones can, and ask that a referral be placed on your behalf so that you can just have that introduction meeting with palliative care to see if it's a fit to meet those needs.
Thank you. Ramy, this is a question for you. How do palliative care teams work with the primary team, whether it's the specialist, the oncologist, the neurologist, primary care physician?
At least in my practice, often. And this is coming from a family who has interfaced with healthcare, and has accompanied family members at visits. I often hear the frustrations from my patients and from loved ones of my own to say, why doesn't everybody just get on the same page? Like, why am I doing this again? Why? And that's one of the biggest frustrations about how our system is set up today, where everyone's practicing in silos. And so I am often reaching out to primary care doctors, especially the involved ones who really want to be kept aware of medication changes or conversations that I'm having with their patients. Specialists, of course. We want to know, of course, what the patients took away from their conversations with their doctors, but we also want to know what the doctor felt was conveyed during the last appointment or where things are heading, so that we kind of can have a unified message and not add to the confusion and frustration and mixed messaging. So I'm often calling, messaging, chatting other providers from different clinics to make sure of that.
Sorry, and Naomi, let me see. I have this question here. Here it goes. So in cases like the one we discussed today, do you ever recommend mindfulness training as a resource to help alleviate emotional distress, as well as physical symptoms like chronic pain and fatigue, things like MBSR?
Great question. Absolutely. A lot of us chaplains and even some social workers and other members of our team are trained in different modalities, whether it's relaxation response, whether it's breathing techniques, physical, other mind-body interventions, and we often use those alongside the psychopharmacological medications, and they work really beautifully together. So we do that inpatient and outpatient really often. So very good question.
Thank you. Jacelyn, another question for you. How is palliative care paid for? And if your insurance doesn't cover palliative care services, how might you be able to access palliative care?
Yes, that's I'm going to say a very complex type of question, just from the standpoint that if it's not covered under your insurance, I think it's going to depend on if there is at that particular health system a out-of-pocket payment that they have set up, and that would be something usually we try to have patients speak with our billing department as far as that, but usually we want to make sure that this is a benefit, that's covered under the insurance. Like, so they usually will try to do like a pre-auth as far as for that. So depending on what health system you go to before you are scheduled for a visit, we do have different systems in place that would speak to you about the payment of that. So it's not a situation where after you have an initial visit, you receive a bill for this payment. So you would be aware that if that's a service that was not covered under your particular insurance. And to my knowledge, most insurances, however, that is something that has been covered thus far in my experience. So UCSF and maybe the PANF providers can speak if they've had any other situation, just very briefly, that they've encountered that around insurance, because I know that brings up anxiety for our patients and families when you're talking about a specialty type of clinic. So I totally understand.
I can speak on that too. I mean, just like a patient may have a cardiologist, right? The palliative care team is a consultant or a consulting team. And so that's how we work together with primary care, just like the other docs and clinics on the team. And yeah, it's covered by insurance, whatever co-pays a patient, at least for our program, whatever co-pays a patient has when they go see another doctor, it's going to be similar to co-pays, deductibles, so on and so forth. It's going to be similar with our visit too. So, and that, at least for the Palo Alto Medical Foundation, we do see patients in clinic, video. We also do home visits in assisted living facility or other facility visits. And that's the same for our services, at least.
Yeah. Where did that question go? Oh, so somebody asked, is palliative care forever? Can you graduate from palliative care? And Meg, would you like to take this question?
Sure. Yeah, it might vary a little bit depending on the program or the clinic, but in our practice, you can quote unquote graduate sometimes if a patient is really stable. You know, we've met them, we've checked in with them, we've kind of figured out what their goals are, and maybe they get to a point where they don't really need a lot of support as far as symptoms or psychosocial support or spiritual support. We might discharge them from our program, but that's with the caveat that if in the future things change and they do get to a point where they need that support, that we would always take them back. And again, I think like Dr. Salah mentioned earlier, if someone decides to consult with the palliative care team and feels like they don't have needs in that area or are not interested in continuing on under the palliative care service, then of course they can disenroll or, you know, not continue to see us. So I hope that helps. I hope that answers the question.
And Naomi, if salient symptoms are more emotional than physical in nature, can people still seek palliative care?
Absolutely. We really look at the whole person, and we know that serious illness and the whole experience of serious illness affects all parts of our being. We don't separate so much the mind from the body. We know that it's one mind body. And so we often see people for emotional issues, existential issues, other kind of coping, distress, or really just being a village for people when they're going through the intensity of caring for themselves and others caring for them with serious illness. So it does not have to be a physical symptom per se. It can be all different kinds of experiences of serious illness.
I think we have enough time for maybe one or two more questions. Yeah, okay. So Ramy, what's the role of the primary care doctor or the referring physician versus the palliative care physician or clinician, and then later the hospice physician? Or
yeah, it's, you know, what I touched on earlier about how we collaborate with other docs and just being a consulting team in the patient's care team overall. So no different than, you know, the role a cardiologist plays or a nephrologist plays. There's the palliative care doc and team in the role that we play. So we're often communicating. With hospice, the way I look at it is often the hospice director or doctor is prescribing hospice related medications. So the patient, although they may not be following up with their primary care doctor as often, given the stage in life and the goals that they have at that stage in their life, the primary care doc is still can be on record and refilling some of the other medications that the patient may be taking. And we are, especially with a transition to hospice, if a patient makes that change, I often kind of stay involved. I think it's a stylistic thing because sometimes it's just a handoff, but I tend to stay involved, at least be available to patients and their loved ones, and sometimes make visits when patients are on hospice. So it's collaboration between the different doctors. And if I can go back to a question Naomi just asked and what Meg touched on, we see for some patients who quote graduate, even though I'm not a big fan of that term, if say they went through a curative treatment for their cancer and now they're cancer free and in remission, and they don't have physical symptoms because the treatment, thankfully it worked, they might still be going through some very psychological or emotional symptoms. Maybe the surgery that cured them of their cancer left them disfigured or unable to eat things by their by mouth, and that carries a lot of stress because of that serious illness. And so we can still follow because of that, at least we do, to help with any psychological or emotional symptoms. So just wanted to clarify that point. I know if you're scratching your heads and thinking, oh my God, what is this palliative care thing? I mean, we spent an hour and I still don't get it. It's because honestly, palliative care, I think by design, is vague and it's nebulous because every person's needs are different, right? And we try to meet them where those needs are. And I think that's a beautiful part of our service and our field.
Thank you, Ramy. That's a wonderful description of what we do. What happens if a specialist or primary care physician or primary team, if your patient's in the hospital, doesn't want to refer to palliative care? How can family navigate that respectfully, but still advocate for the care they think they're need? And I'll just open this up. Who wants to take this?
I can answer it. So there's lots of different reasons that different providers don't want to have palliative care. So I think first is understanding why. Is it a misunderstanding of what it is? Is it they're feeling that they're caring for the issues at hand? Ultimately, though, I would say, and it is difficult because palliative care is usually referred physician to physician. So I think it is really hard when your primary physicians are not on board with it. I would say ultimately, your job and the job of caregivers is to get the very best care for your loved one as you possibly can. So I would find other ways, whether it's the nurse on the team, whether it's other people on the team. And it is also possible in many cases to contact the palliative care services yourself. I know that that's a big risk because there's a power differential and you don't want to upset your providers. You want to show that you're also working with them. Ultimately, though, there are different creative ways to get in touch or to contact or to be part of the palliative care service. And I would say that if you really feel like there's a need to continue that conversation respectfully with your providers, understand what they're thinking so you may learn something, and then ultimately look for that service in other ways to make sure that you get that for yourself or your loved one.
Thank you. And I think it's time to wrap up. We had other questions and I'm sorry that we've run out of time, but I will pass it back to Redwing.
So really just to say thank you again to everyone who showed up to find out everything you want to know about palliative care. Hopefully you found out a little bit about what you want to know about palliative care and that you will have a little more understanding in case you do need to get a referral or work with someone or yourself who is in need of palliative care, to understand that palliative care, it can be accessed at any time during a serious illness, and it's super important. And here's the slide that shows you that we have a lot of amazing palliative care teams in the Bay Area. We are incredibly lucky here. And I think these slides are going to be available, or at least this resource slide will be available to you. And there will be a survey sent out to you after this webinar. We really hope you'll fill it out. And if you need more information, you can probably add that on to your survey as well. Thanks to this incredible palliative care team that came together for this webinar. And just thanks to all of you who listened, and hopefully you can now talk to other people in your circles because you have a better understanding about palliative care as well. This is an important web to keep weaving around our culture of healthcare. So thank you, thank you, thank you. And we'll see you again next year.